round and round. Got it. Got it. And oxygen is good. All right. So obviously the second one of these is the heart failure talk. We're not doing that today. So we're going to talk about the other two a little bit in the course of this. So respiratory failure, right? Two flavors, hypercapnic and hypoxemic. Hypoxemic, PO2 less than 60, failure of gas exchange, basically failure of lung to function as it needs to. Hypercapnic is ventilatory failure, so PCO2 that's elevated. We're not going to, and again, we're not going to get into that today. That's next lecture, some Friday afternoon maybe. I'm going to just go back to a little bit of basic physiology. So back to, remember these from medical school, the oxygen cascade. So starting at atmospheric pressure, dry air, oxygen is 159 millimeters of mercury roughly, right? Barometric pressure 760.21 times that. With the first inspiration, as soon as air goes through the upper airways, it's fully humidified. So now you have moist air, and we'll round that off. So it's roughly 150 millimeters of mercury now for the PO2, if you account for the water vapor in there. Moving down into the alveoli, now you have a PO2 that's around 104. What has reduced it at that point, right, is the CO2 that's coming back from the periphery and back into the alveoli, and the uptake of oxygen at that level. There's going to be a little bit of venous admixture for things like the bronchial veins and coronary sinus. Drop it another few points, and then you move on to tissue extraction in the periphery. The big consumer here, right, is the brain, which takes the most and drops down the PO2 to something around 35 millimeters of mercury. And then the final step is just in the mitochondria, where it's down to 5 millimeters of mercury or so. Lots of places for things to affect PO2 at any level in that cascade. We're going to talk for a couple of minutes about mechanisms of hypoxemia. There are 5. Most of these aren't things that really come up a whole lot in clinical practice, but we're going to run through them just for the sake of completeness, and so we don't forget. First one, decreased partial pressure of oxygen. So for those of us who live at sea level, not really an issue, right? So for us, again, dry air and atmospheric PO2 is around 150. Summit of Mount Everest, or Annapurna, PO2 is closer to 53. So obviously, there's obviously a good cause for hypoxemia, and obviously an easy answer, you just bring oxygen. Not really something, it's great physiology, especially if you start talking about populations that live at those altitudes, not those altitudes, but 10,000 feet or higher, but not the topic for today. Next mechanism of hypoxemia. You have a young, healthy male, has a history of GERD, comes in for an elective EGD, uncomplicated procedure, did not aspirate. They roll him out of the procedure room, off to PACU, and someone notices a few minutes later that his stats are in the 80s. So what happened? Why is he hypoxemic? What's that mechanism? Pardon? Won't breathe. Oh, well done. Won't breathe. Hypoventilation. Makes up for that. That must have been what you learned in those 2 weeks you spent with us. So hypoventilation. In the alveoli, you've got oxygen, CO2, water, and nitrogen. If water and nitrogen are always constant, which they are, then the amount of PO2 and CO2 has to be a constant as well, right? This is basic gas laws. So other things being equal, healthy lungs, if CO2 is going up from hypoventilation, O2 is going down. It's being extracted and carried away. So this is a simple one, and it's easy, it's predictable. You don't need any fancy imaging or flat gases for that. You just need to wake him up, right? So the flumazenil, the Narcan, poke in the ribs, whatever it takes. He just needs to wake up, and he needs tincture time to clear those things. Worst case scenario, you breathe for him, but that scenario doesn't usually happen. All right, so that's 2 mechanisms. I apologize. My fonts changed between my desktop and here, so I apologize if things aren't lining up quite right. So these are 2 patients. The first one has advanced pulmonary fibrosis, and I think you can see on that image that you can agree with me that he's got increased markings in his interstitium. And on the CT, it's also pretty obvious, right? That interstitium looks thick. The other patient doesn't have any lung problems, but has an autoimmune hemolytic anemia and shows up with a hemoglobin of 3. So what is that defect? They both have the same mechanism for hypoxemia. And what would that be? Any takers? How about a diffusion defect? So diffusion is just a passive process getting oxygen from the high pressure areas in the alveoli to lower pressure in the blood, right? And there are 2 parts to it. The first part is the part we always think about. It's movement across the alveolar membrane. But the other part of it is actually getting into the red blood cell and combining with hemoglobin. Sometimes the Europeans call it a transfer as opposed to diffusion. It might make better sense. It's sort of easier to conceptualize that way. In any event, capillary transit time is about 3/4 or about 0.75 seconds. And given that that whole process can be accomplished in a fraction of that, like a third of that, it is hard for the red blood cell to leave the capillary bed without full saturation unless there's a really marked decrease in the transit time or a really severe limitation to diffusion. Realistically, even though we always talk about it or always gets listed, it's probably not a real clinical cause of hypoxemia. We use it to measure the function of the alveolar capillary membrane, right, in the PFT lab. But from a day-to-day practical standpoint, probably not that important. Treatment, easy, give them more oxygen. Or increase how much oxygen carrying capacity they have. This is something that I might think of if I have somebody who's really in trouble from a respiratory failure standpoint and really hypoxic and they're anemic. Someone that I might not give blood cells to, I might push their hemoglobin up a little bit if I need more trucks. All right, so that's 3 mechanisms of hypoxemia: decreased partial pressure of oxygen, hypoventilation, and decreased diffusion. And none of them really drives what we do on a daily basis, but it's all part of the process, right? So the next 2 are the 2 that really make a difference from a day-to-day basis, and that's BQ mismatch and shunt. BQ mismatch. In normal healthy lungs, sitting up, standing up, you have better blood flow at the bases, right, because gravity sucks the blood down, and then you do at the apices. And similarly, you actually have better ventilation, somewhat better at the bases than you do at the apices, but it's not as big a difference. So you end up with a ventilation perfusion mismatch, even in normal healthy lungs in day-to-day life, right? The average VQ ratio is about 0.8. We don't walk around with a normally perfectly matched VQ ratio. Unlike shunt, you can usually fix VQ mismatching by just giving oxygen. And this is what we see every day, right? This is really why we run into people who are hypoxemic. So it's someone who's wet, someone who's got pneumonia, or someone who's got ARDS. And it doesn't take a lot of imagination to see that somebody like this guy at the apices, ventilation is going to be a lot better than it is at the bases. And the bases are pretty much drowned and not going to get a whole lot of gas exchange going on down there. Similarly, this person is going to have, in the area that the pneumonia is the densest, is not going to have a whole lot of gas exchange, but around the periphery, where only some of those alveoli are involved, some are going to be filled with pus, some are going to have a little bit in them, some of them are still going to be open, it's going to be patchy, right? It's not uniform all through the process. And then on the other side, I don't know if I have a pointer, on the other side, do I have a pointer? This thing, yeah. So on that side, then you've got an area where maybe she's breathing harder and taking bigger breaths. She might actually be over-distended. So you're going to have VQ mismatching in the other direction. So you've got the whole scenario played out in one set of lungs. And similarly, there's all sorts of stuff going on here, so you're not going to have good matching. Contrast, this patient has shunt, right? That whole right lobe is mostly gone. A right lung is mostly gone. The airway is way over. It's hard to see, but it's way over here. You don't even see a heart border on the left side anymore because you've got such bad mediastinal shift because most of the right lung is atelectatic. There's no gas exchange through that lung, right? It's really all, except for maybe at the very tippy top, it's all just perfusion. And if you look at a CAT scan of the same situation, again, you've got a lung that is basically drowned on that side. There's no real gas exchange going on there. There's just perfusion. So that's pure shunt. But we don't see that, right? That's really not how, that's not what you encounter in a day-to-day scenario typically. These are people that you got to hope that you can go in and suck something out and open things back up because oxygen isn't going to help you. And this is why. So now we're really going to go to physiology for a couple of minutes. This cartoon is actually showing a setup where you have two alveoli, one that's happy and healthy, one that's completely drowned. So it's a 50% shunt, all right? You have, you have blood coming in over here from the periphery with a PO2 around 40, right? And it goes past the first alveolus here, which is, again, doing fine, PO2 of 100. And when it comes out the backside of that, the other end of the capillary bed, PO2 is 100. It's fully saturated, just like you would expect it to be. Goes past this alveolus that's completely plugged up. Nothing happens. There's no way for gas exchange to take place. So the PO2 is still 40 over here. And so coming into, leaving then the lungs, the blood coming out is going to be the mixture, the average of that 50-50 mix. But it's not the average of the PO2, it's the average of the oxygen content. And if you follow me for just a second, so oxygen content is O2 bound to hemoglobin and the dissolved oxygen, right, in the blood. The dissolved portion is trivial, so we'll leave that to the side. So it's really just the amount bound to oxygen, which you can calculate if you remember the equation, which none of us ever does. So remember the oxyhemoglobin dissociation curve? So for the blood that's coming back from the periphery, that venous oxygen, at 40, the oxygen content for somebody who's got a hemoglobin of 15 is around 15. And the one who's and that's the bad alveolus, and the good one is up here with a PO2 of 100 and an oxygen content around 20. So the blood that's coming out is an average of those two numbers, or an oxygen content of around 17.5, which would put it somewhere around here, which is closer to 54, which is what that shows you on that side. Does that make sense? And then if you go ahead, so now say I decide I want to fix this problem, I crank up the oxygen. So now my PO2 in the happy alveolus is 400. Well, that's great, but I'm going to come out on that side with a PO2 of 400. The bottom isn't going to change. But if I go back to my oxyhemoglobin dissociation curve, because I'm already on the flat portion of the curve, putting my PO2 up to 400 isn't going to buy me anything. So my average is really going to work out to be just what it was before. Does that make sense? So shunt, you can't fix with oxygen. Of course, it's also hard when you're in that situation to turn the oxygen down and convince yourself that it's not helping. It takes more of an act of faith than I think I usually have. But the good news is we rarely see shunt of that degree. What we see is this kind of shunt, where you've got one lobe that's down. Or this kind of shunt, where you have areas over here that look like liver, that really don't have any gas exchange going on, that are being well perfused. But then if you look at the whole thing, that's just what? It's VQ mismatch. You have areas of shunt, you have areas that are patchy. So realistically, short of having an entire lung that's atelectatic or something along those lines, all we really care about is VQ mismatch. And then that means that all we really care about is trying to find ways that we can improve oxygenation. And there are tricks for that. I have more tricks if I have somebody attached to a ventilator than if I don't, but there are ways to do it. All right, good so far? So improving oxygenation. this is where we're going to back up a little bit for some of our newer learners, but I want to make sure at least you have some basic appreciation for what those things are that the RTs are hooking up to the flow meters on the wall. So obviously first is what? Nasal cannula. That's easy. You can buy yourself 2 4 liters of oxygen. You can go up to 6. But beyond that, it doesn't really help you very much, because beyond that, it's really drying, it's uncomfortable. You're not, if that's what you're doing, you need another modality. The other thing is, please do not call me and say that somebody is on 4 liters of nasal cannula, therefore they've got an oxygen of, that they're getting 30% or they're getting 40% or whatever. You have no idea what the percentage of oxygen is that they're getting. Partly because half the time it's in their eyeball or in their ear or on the floor, right? But the other reason is that if I'm breathing, if I'm getting, say, 4 liters a minute nasal cannula, and it's sort of in my nose, and I'm breathing 5 or 6 liters at rest, all right, that might make up a reasonable percentage of the air that I'm breathing in. But if I'm sick, I'm febrile, I'm anxious, and I'm breathing 10 or 12 liters a minute, that 4 liters is starting to look a little puny, right? I'm going to be pulling in a lot more air from the outside than I am from that nasal cannula. So the reality is you never have any idea what somebody's getting from that standpoint when you get the flow. You don't know. So what can you use? You can use a mask. There are simple masks that the RTs will plug in and they'll turn up the flow and they'll tell you, oh, they're on 10 liters, or they're on 8 liters, whatever. It's not unreasonable. It gives you more oxygen. Because it covers the face, you have a better chance that they're going to actually be breathing more oxygen. They don't fit particularly well, right? And they've got holes. I have exhibits. They've got holes on the sides that are meant to be exhalation ports. So if you have something like this, and I mean, look at this. There's no way this fits any human being's face, right? So you're going to entrain oxygen no matter what you do. And how much you entrain is relative to what the flow is going to govern how much you're actually getting from this thing. You can move a step up from that and do these Venturi masks. So, and we use these, but this part governs what the percentage of oxygen is that you're getting. And the way we set ours up is they're up at the wall, at the flow meter. If you next time you have a chance to see one of these, take a look at it. See that little hole right there, that little aperture? So what that does is you can rotate that thing. And if you close it down, then there's going to be virtually no air entrained through this. And so the flow coming out from the wall is going to basically all go into the mask. And you'll be approximating 100% or 90%. If you open that up, you're going to entrain air from the outside. And depending on how far you open that aperture, you can entrain more or less room air. And you can change the percentage of oxygen you're getting. So this can give you something from like 30 to maybe 90%, at least in theory. All right. Same issue around the fit. And so forth, but at least you have a better sense for what you're really getting. And then non-rebreather. So non-rebreather gives you a reservoir, right, that you can have now. So the oxygen's going to flow through into the reservoir. So when I take that next breath, I'm not just going to be entraining air from the outside or from those side holes. I'll be entraining air I'll be pulling air in, right, from the reservoir because it's full. So I'll be able to pull that in, more oxygen that's like stored up in there basically. So that helps take care of entraining outside air. If you're really in trouble and you're not here where we've got all sorts of fancy things, but you're at the aid station in Jackman or you're at one of the health stations on one of the islands and you've got somebody in trouble and you need to find another way to put oxygen in, you can take your non-rebreather and you can put tusks on it so that you have corrugated tubing out either side. So now I have a reservoir on either side. So I've got the reservoir at the bottom, I've got this on either side, so air is going to be flowing through all of this. So as I breathe in, I'm going to be pulling air mostly from all those other directions rather than from the great outdoors. I mean, it's crude, but it might buy you something if you're in trouble. All right. Moving on, high flow, we'll come back to that. CPAP or BiPAP, depending on the moment. So a more fitted mask, tightly fitted, less chance of having stuff entrained from the outside. So much of this depends on how this works in somebody in respiratory failure, depends on who your respiratory therapist is. If you have somebody who is good and they know how to work with a patient and get their attention, make sure the fit is right and tweak it with them and sit there and spend some time, you could do okay. If you have somebody who doesn't have that skill or doesn't know how to do that, especially for somebody, a patient who's anxious, can't breathe, and now you're trying to clamp something on their face, it's not going to go well. There's just no way. But in the right circumstance, it gives you better oxygen, better control of your oxygen. You can control the pressure that you're putting through the system, so you know how much they need to be able to get the air in. If you use BiPAP, you can actually set inspiratory and expiratory times, kind of like a ventilator, right? You have to be careful to know when not to use this. And I think that's the thing that worries me the most about these. So make sure that the person that you're using this on has airway reflexes. You can't put this on somebody who's comatose and can't protect their airway, if only because you always end up pushing air into the stomach to some extent. And if they regurgitate, it's all going to go into the mask. And with that positive pressure, it's all going to go right back down into their lungs and then right out into the periphery. And that won't end well. The other thing is you have to wonder about somebody who has maybe an esophageal problem, somebody who has a big hiatal hernia. I might wonder about if this was the best option because, again, they're always going to get a lot of air pushed down into their gut. And if you have a big hiatal hernia, you're going to have a regurgitation issue. So you just have to be a little bit thoughtful about using these. And then last, of course, is intubation. And if I can intubate somebody, I've got tricks. But that's not really today's talk. That's another talk. So I want to spend a few minutes talking about high-flow nasal cannula, because I think a lot of us spent a lot of time looking at high-flow nasal cannulas on patients in the last year and a half or so. A little bit more complicated system. So you have, obviously, the prongs and the tubing, right? You have a humidifier with the bag of fluid that runs down into that. There's the flow meter on the wall, right, to give you your oxygen, and an air oxygen blender so that you can set whatever you want for your percentages. High flow rates on these, like up to 60 liters a minute, means that essentially no room air is entrained. It doesn't have a chance, right, just because of flows you're putting through the system. These same high flows mean that you're washing out the expired air, so there's less dilution of oxygen with the next breath that they take, right? It's heated, it's humidified, so it's more comfortable than some of the other options. Nasal prongs are more comfortable than a mask and less likely to be upsetting to somebody who's in a little bit of respiratory distress, so probably more likely to get worn. It decreases the dead space. I'll come back to that in a second. And the other thing it does is because the flow is so high, it impedes expiration. So effectively, you end up increasing your lung volume because to some extent, air is just being held out there, right? You've given the patient positive pressure, just like PEEP, and you basically recruit alveoli that are otherwise not participating in gas exchange. And so you've increased your FRC, and that is all to the benefit of oxygenation. Dead space, combination of anatomic and physiologic, right? And there's certain disease states in which the physiologic part becomes much more dramatic. Someone with bad emphysema, where they have destruction of capillary alveolar units, a PE, ARDS. I think of ARDS as an oxygenation and shunt problem, but it's also a dead space problem. And the amount of dead space early on is actually linearly proportional to mortality. So dead space in ARDS is important. At rest, about a third of every breath is rebreathed from the anatomic dead space. So when you finish exhaling, you've got all that stale air that didn't make it all the way out to your mouth, right? It's sitting in the conducting airways. So that is the first air. This gets back to the alveoli when you take the next breath. With high flow, you can wash out that anatomic dead space because the flows are so high. So it decreases the amount of CO2 that you take in with that next breath, right? Now you're getting fresh air, more oxygen. That also means because you're breathing less CO2 back in, you're also going to have less coming back into the system. So you can, even with a lower respiratory rate, and a lower minute ventilation, you'll be at the same CO2. All right. And we've seen this. A lot of us, right, in the course of the year, you see someone that go on high flow and you come back and you realize their respiratory rate is down. That's probably part of the mechanism for that. And then by flushing the anatomic dead space, you also help get rid of you decrease the amount of total dead space in diseases that have an elevated dead space. Study looking at 20 post-op CT surgery patients, most of them cabbages. This was really just to get a chance to see what some of these basic respiratory variables looked like. And the way they did it was they used electrical impedance technology to image lung volumes. And so you can see lungs getting bigger and smaller depending on, and as they get bigger, as your lung volumes increase, that's increased impedance. So they did this on 20 patients just to see where they would land with these basic variables. And what they found was they had compared them to low flow oxygen. Patients with a high flow had almost 5 times the impedance of the others. It's not a one-to-one, but it clearly correlates with a much larger lung volume with the high flow than with an end expiratory lung volume than did with the normal oxygen. The mean airway pressure in the system with normal low flow oxygen, essentially 0. With the high flow, it was 27 millimeters of mercury. That's a huge improvement. I do well if I can get that on a ventilator unless I start to think about it a little seriously. So that mean airway pressure correlates then to increased recruitment, better oxygenation. With that, they also found their respiratory rate dropped by almost 4 points. Their Borg scores went down somewhat. That's a measure of dyspnea. And their PF ratios improved. So very basic markers for respiratory function all improved with high flow. The Florally trial in the New England Journal a few years ago did a prospective comparison between high flow, regular low flow O2, and non-invasive ventilation. There were a ton of exclusion criteria. I mean, tons. So basically what it worked out to be was a trial of high flow nasal oxygen in pneumonia patients, which is fine. What they found, if you look at the top graph, they found was a trend towards decreased incidence of intubation with high flow. So it's clearly better than the other two in that regard. If that is the incidence of intubation, the high flow group does better, but it didn't reach statistical significance until they went down and looked at the ones who were sickest. These are the folks who had a PF ratio less than 200. So the sickest of their group, and here it did reach statistical significance. So it suggests that there might be room for this, or this might be the modality you would reach for first in the people that were the sickest, that you were most concerned about. They also showed decreased mortality with the high flow, or an increased probability of survival with the high flow. And not really clear why that was, unless it is just the fact that you avoid all of the complications that go with being intubated, which are substantial. It's just a schematic to sort of summarize the different aspects of high flow that make it acceptable to patients. So you can go, again, high flows up to 60 liters per minute. With that, you get increased mean airway pressure. Because you have increased mean airway pressure, you have increased end expiratory lung volumes, increased recruitment, increased lung compliance, the increased lung volumes and recruitment give you a better PO2. You get dead space washout, and the combination of all of those things means that you'll see the patient has lower respiratory rate, decreased minute ventilation, decreased work of breathing, and overall, all those things translate to better comfort. This is a schematic that I borrowed from Suba, from a presentation he and I worked on together last year. And basically the idea is high flow is great, but you need to remember how to balance using a good technology with knowing when to stop using a good technology and move on. This was something there was a lot of tension with in the last year because we would routinely find that we were being called for patients who were on 100% high flow and had sats that had been falling steadily through the day. And now we're 90 or maybe 89. And the question was, well, now do you want to intubate them? I would have liked to have intubated them before that. I mean, I'm good and I like the challenge as much as the next person, but that doesn't leave a whole lot of wiggle room for that intubation. Because invariably, when I give them drugs to sedate them and to paralyze them, those sats are only going to go down. So you need to know when to say we pack it in now and go on. About 30, maybe 40% in the various studies of people on high flow will end up needing intubation. So the major risk of this modality is that you get so entranced with it that you forget to move on to the next step, and you'll hurt somebody by delaying that intubation. Oops. Studied 175 patients who failed high flow, which is defined as needing intubation. Of the ones who failed in under 48 hours, the overall mortality was 39% for their ICU stay. In the ones who failed later, it was over 66%. That's a pretty striking difference. The patients who failed earlier, got intubated earlier, had better extubation success and more ventilator-free days. So the short message is, think about it, and if they're going to fail, make sure they fail. Don't drag it out. Go ahead and intubate them when they need it. Delayed intubation, one thing is people get hung up, they watch the sats and don't necessarily always pay enough attention to what the acid base status is. That's important too, and you may not see it until it's a little bit late. There's potential for worsening of other organs. You can you can get sort of caught up in what you're doing and forget that, oh, maybe they have an acute kidney injury, or maybe their liver's not so happy. It may be longer immobility. Instead of just putting someone on a ventilator and dealing with their respiratory failure, if you drag it out longer and longer, it may be that you're giving them more of a chance to be sicker for longer. And there's also an issue about nutrition. It's hard to feed these people. And so at some point, I can't very well put an NG tube in with somebody on high flow nasal cannula. I mean, we do, but it does sort of defeat the purpose to some extent. So that becomes an issue over the long haul too. There's something called the ROX index, which was a group tried to find a way that they could predict who with pneumonia, and they were specific, these were patients with pneumonia, who on high flow would not require intubation. And so what it is, it's the SpO2, the pulse oxsat, to the FiO2 ratio, so sort of a PF ratio, which we all think about, right? And then that over the respiratory rate. So these are values you have readily at the bedside. They don't cost you anything beyond where you've already used. And you can track them easily. In their derivation cohort, the number that they came up with, greater than 4.88 at 12 hours, so I probably would have called it 5, were less likely to be intubated. And if you look at their graph, for the patients who were greater than 4.88, they actually did pretty well. Just under 80% managed to avoid intubation. The ones who had their other marker less than 3.85 did quite poorly. There's a pretty clear split here. So they went ahead, they took that, and then went back and looked at nothing. So they went back and they took, I don't know which other buttons to push. They went back. No, I'm trying to advance. That's okay. I only have a couple more. Yeah. We'll go with that one. Thank you. As I say, I can do it. So they were validation cohort. They basically went through and looked at the same thing and went through and validated the same thing and found the same sort of thing, right? They had that 4.88 for their cutoff seemed to be a very good divider for who was going to make it and who was going to fail. And they also pointed out that if you looked at the people who failed, the risk of death in the hospital went up substantially once you started getting past that 12-hour mark. So their hypothesis is maybe we should be using this sort of an index to look at people who are on high flow, and especially in that 12 to 24-hour window, start to do it, maybe we should do it hourly and see which way they're going. And if it looks like they're not going to stay in that top group, go ahead and intubate them. It's a reasonable hypothesis, and it might be worth taking a look at in a more coherent fashion. And then the last thing I was going to talk about was prone positioning. That's the other thing we've talked a lot about this year. So prone positioning, here's your patient, bad ARDS, lots of VQ mismatching there, right? And you have better flow at the bottom, better perfusion at the bottom, because again, gravity sucks the blood down. And and you have better ventilation up at the top, just like you did in a normal healthy person who's up and walking around. And it also is accentuated by the fact that ARDS is a dependent disease. And so the upper parts tend to be more open, the baby lungs, if you will, and the lower parts are drowned. So if I turn this patient over onto their belly, I now have better flow, better perfusion at the bottom, just like I always did. And now my ventilation is better down there as well, because those are the lung units that are already open. And because I've improved my VQ matching, I should be able to improve my oxygenation. There's good data for this in ventilated patients, right? That's of course I'm blocking on because I'm sleep deprived, but there's good data for it with better survival in the ventilated patients. The data for the non-intubated patients is maybe not so robust, but this is, for example, a small group from last year. And if you look before prone and 1 hour after prone, that's a pretty good improvement in their PO2. It's not insignificant. It didn't hold very well after they went back. A fair number of these patients fell back pretty quickly, but they do when they're intubated too. With the intubated patients, we spent a lot of time last year going back through and revising our proning protocol. And I have to say the nurses in section 2 of SKU are absolute masters at it. It doesn't matter how big the patient is. It doesn't matter how they're configured. They can have them over on their belly and in perfect position in maybe 5 minutes. It's really astonishing. The advantage that we have with the intubated ones is I can keep them quiet and sedated, and I don't have to worry that they're going to tell me that they're uncomfortable. A fair number in the studies that I was looking at for the non-intubated patients who are prone, a fair number of patients just can't do it after a while, right? They last an hour or two and then they're done. And that's probably what is the biggest drawback for this in the non-intubated population. Intubated patients spend 16 hours on their belly and then go back for maybe 8. And you just can't do that for people who aren't tubed and sedated and paralyzed. And I think that was my last slide. Questions? Yes, sir.
Yeah, we'll start with questions from the audience, and then we will go to Zoom after that. If you could just repeat the question so the Zoom audience can hear the question.
Okay.
The point you made about sort of normal I think it's just a trend trend respiratory. And when it starts to come back up, you get the rocks index, or what is kind of respiratory. Is that really what the bottom line is?
That really is kind of what they're doing. They're just trying to make it more specific than that, I think. Oh, yep, nope, I already forgot. See, I didn't even make it through one. So the question was, in knowing when to fold it in with the high flow and decide that you're going to intubate them, instead of doing a ROX index, why can't you just trend what their respiratory rate's doing and see what that does? I think you can. I think the problem might be, and I would have to play with numbers, I think, to know that, but I think the problem might be you might give up some of your discriminatory power, and I think that's what they were trying to do, is really nail it down to a fairly specific range. But yeah, absolutely. I mean, the first thing you always do, right, is look at the patient before you get out the numbers. The first thing you do is look at them. Yep. Yeah, I know what you're asking. It's sort of, and I always visualize that myself. Oh, geez. See, all right, so the rule is you shouldn't do this if you haven't slept for the last 2 nights, because it's hard to keep the rules straight, okay? So the question was, I said that ARDS was a dependent disease. And so would I be concerned then when I put someone on their belly for many hours at a time, am I now going to just recreate it in the other direction so that now what is used to be good lung is now drowned lung and vice versa? I always, and I do wonder about that when we go through this. The reality is it doesn't happen that fast. I don't know if we did it consistently for days. I mean, these are people, right, who've been on their backs for a few days by that point, or at least for a couple of days, very consistently. It doesn't rearrange itself that way. It just doesn't. It takes longer. Lungs are like, it's kind of like a sponge, right? And even if you flip it over, it doesn't drain and empty fast enough to make up for the difference of where you are. But I think that's something, I guess the question I would have, and I haven't seen it, the whole idea of the baby lung being the dependent disease and the cleaner lung up top, that came from the Italians doing CAT scans of people with ARDS and just identifying that as what they saw routinely. I haven't seen somebody do the same thing with people who have been on their bellies for like 16 hours. And that would be interesting, I think, to see what that did look like. Yeah.
Thank you. Question about sort of discriminatory determining when you go to high flow, or how you make that decision about high flow when you go to high fat versus particularly with regards to, because it sounds like high flow has some physiologic benefits that are not dissimilar. 5% wash up, dead space and stuff. So how do you make that decision? Which direction you go with somebody that's showing that they're not low flow, ash, or whatever they're not making? When do you decide, well, let's go this direction or let's go this direction?
So the question, I got it this time. The question is, how do you decide if somebody's failing on the easy therapies, the mask O2, for example, how do I decide that I'm going to go with high flow as opposed to non-invasive ventilation? Assuming that I have somebody who has respiratory drive, because if they have impaired respiratory drive, they need BiPAP, so they have a respiratory rate. So we'll leave them to the side. If it's just the other group, my bias is to go to high flow, and my bias is because I think it's more comfortable. I think it's easier to get patients to settle in and use it. I can leave someone on high flow for days, whereas if I put them on non-invasive with one of those masks for days, at some point their nose is going to fall off. It's really hard, no matter how careful you are, not to start to get breakdown over the bridge of the nose and maybe over the cheekbones. It's harder for them to communicate, which becomes an issue as far as just like delirium and that sort of thing. And I can still give people, if they're not really sick, I mean, if they're on really high flows, I'm not letting them eat anything because I don't want to intubate somebody with a full belly. But if they're on lower percentages of oxygen on high flow, they can get some nutrition in, which is harder to do with non-invasive. And the other thing, which at least a couple of people on the Zoom will appreciate, because having seen a couple of the names there, I got drilled into my head a long time ago that CPAP was the work of the devil. And I can't quite get past, I have that bias sort of in my head. So that's not a very scientific answer, but it is, yeah, I think so. Any other questions? I see chats. Am I supposed to do something with these? Oh, sorry. No, as I recall, in the Florally trial, the question was, did they move from one modality to high flow if they looked like they were failing? No, they stayed in the group they were in. You know, yeah, you know, the question is should we put people on high flow earlier before they get into trouble with one of these other modalities? And you can, but it limits where they can go in the building. It is more labor and resource intensive. And so you don't want to waste it on people who don't really need that. In the last year, we've probably had people on it maybe earlier than they really needed to be sometimes, because people sort of got it in their head, oh my God, they're on 4 liters nasal oxygen, high flow. And maybe a bunch of those people maybe didn't need that. But a lot of it's just practicalities.
Click on the chat. If there's anything.
I'm going to have to put on my glasses. Common statement made by patients with COPD, don't give too much oxygen, they'll stop breathing. Can you comment? So a question is, common statement made about patients with COPD, don't give too much oxygen, they'll stop breathing. Can you comment on this? I'd go back to my original guidelines. Oxygen is good. You always, I mean, everyone worries about that people have, that some of the COPD patients are really being driven by only their hypoxic respiratory drive. And if you correct that, then they'll stop breathing. The reality is, if they're in that much trouble, I really don't care. They just need to be intubated and breathed for anyway. So I can't think of a universe in which I really wouldn't just treat the hypoxia. The other thing is, your average COPD patient with an exacerbation, even if they've got a pneumonia, it doesn't take a lot of oxygen to improve them. They're not, if they're on high levels of oxygen, there's usually something else going on, not just a standard COPD exacerbation. Getting there.
Hi, Dr. Lerwick. Can I ask a question? Can you hear me?
Yeah.
Okay. Hi, this is Victoria. My question was about BiPAP and not putting patients on if they're at risk of aspiration. And I feel like there's a lot of patients in the hospital that are kind of like mild to moderate risk of aspiration. And I was just wondering what the threshold is to not put someone on BiPAP because you're worried about them aspirating. Like if they're like, maybe they're having some aspiration, but that's not what they're there for. Is it just best to kind of stay away and put them on high flow, or?
I don't know that there's a really clear answer for that, right? It's it's going to be situation specific and practicality as well. So again, high flow, you're limited to where you can do it. You are though as well to some extent with non-invasive. And it also would depend on the circumstances. If I had somebody who was DNI, and I was trying to see if I could come up with something, I might use non-invasive as a sort of a rescue and see if I could sort of get away with it. But I would want somebody to be in a place where they could be closely watched. But I don't think I have a specific answer for that. That really is just a judgment call. I think as we have better equipment, better technologies, we may be able to get a little bit more careful with some of the things that we have been doing. So we may be able to practice a little bit more safely than we had been.
Gotcha. Thank you.
Dr. Vanderkloot wants to emphasize my point about reevaluating the efficacy of high flow. Thank you, Tom. Text code, text code, text code, and please submit questions. I think that is it.
All right, well, thank you very much. It was a great review, and another round of applause for Dr. Lerwick. And it's great to be back in person and see people on Zoom, and we pulled it off. So congratulations on that. So get some sleep.
There you go.
All right, thank you.
I'm going to take my toys. I'm going to get some sleep. Absolutely.